You are most welcome to a weekend update on the pandemic. What's going on? Well, we're going to look at the United States later on and a few other countries, but I want to focus on Europe to begin with, because the trends in Europe are definitely upwards. And there's quite a lot of, I think it has to be said, alarm amongst European governments. So is this justified? Let's have a look at it. What is going on here? So first of all, I want to think about where we are at in this pandemic. Kind of how far through are we? Are we near the start? Are we near the middle? Are we getting towards the end? Is it the beginning? Is it the end of the beginning? Is it the beginning of the end? Where are we at? And to do that, we've got to look at data. So current antibody studies into SARS coronavirus 2. So New York, it was about 23% of the population had antibodies. London 18, Madrid about 11. In the general population lower than that, many nation surveys reporting single digit figures, sort of 6, 7, 8, 9, 10%. And Mike Ryan from the World Health Organization, he's the boss of emergencies, I think, said we've got a long way to burn just recently. So is this accurately reflecting the situation? Well, the antibody studies, because the antibodies don't last long and some people don't seroconvert to make antibodies, they're always going to be an underestimate of the people that have actually been infected. And we think the real long-term immunity is coming from the T cells rather than from the antibodies. So we think we need to look at these as absolute minimum figures. The real figures are actually higher than that. These are the real figures in terms of the antibody survey, but the actual number of people that have been infected, and therefore, in my view, are going to have a good level of immunity, is much higher. So I can't really say we're at the middle of this in terms of a natural evolution of the pandemic. But that probably wouldn't be a bad guess at the moment, but I don't like to guess because it's not based on data. But more on this later on, and we'll see how we go on today. But there's evidence that immunity is more widespread than these surveys would indicate. So things may not be as bad as people are thinking sometimes. Now, just before we go on, I'm going to do my COVID symptom tracker app today. Now, if you're in the United States, this is the, where am I? There we go. Where am I? If you're in the United States, this is the icon to look for. This Zoe COVID symptom tracker app icon. And the reason I'm doing this now publicly is because I want more people in the United States to download the US version. So report today, even if you're well. So let's report today. So me. Now, it's important to remember here, and a lot of people even in the UK don't know this, you can put children on as like an associate account. And the COVID symptom tracker people, Tim Spector and his mob, really need more data from children. So if you want to add children as associates, that would be good. And it would be ideal if whole schools would do this, so we could really pile in the data on children, because we really need more on that. Right, so I've actually never had a COVID test. Today, thankfully, I feel physically normal. And that is it. And of course, you can browse through for lots of other things. So I'm now going to turn my phone off in case it rings. Right, so really that is it. So it doesn't know me personally. It's not geolocated. It's just valuable data. So valuable data, and we've benefited from that many times on this channel, explaining things that are happening through the data that's been collected on that. Often way ahead of the government data. Often way ahead. Now I'm going to start off with the UK today. Prime Minister said second wave is inevitable and is coming now. 1 in 5 people in the UK are subject to some form of lockdown. So we're going for this sort of regional, localised lockdown approach, targeting particular groups and particular areas. And I must say that makes a lot of sense to me, providing everyone else is doing all of this. Which is why I leave that poster there, so I don't forget, so you don't forget. We're in a pandemic. I'll be taking that down when the pandemic finishes, because it's just so essential to keep going with this basic, really basic stuff. let's get the simple things right first. I've been saying that for a while. Right, Matt Hancock, the number of people in hospital. Matt Hancock is the Secretary of Health in the UK. The number of people in hospital is doubling every 8 days or so. We will do what it takes to keep our people safe. So Matt Hancock here is saying that the number of people in hospitals is doubling every 8 days. Therefore, more dramatic measures may be needed. And statistics is a wonderful science, and it's a beautiful science, and I wish I understood more of it. But people can select bits that they want for themselves. That's the problem. So let's actually look at it. Now, this is live. This is live from the government website now. Patients admitted to hospital from COVID-19 admissions at the moment. So this was obviously the peak here, the dark days of April. Now you can see is right. Things are increasing here. So let's actually look. So the latest date we have available there, England it was 183, Northern Ireland 0, Wales 65, and that one is patients admitted to hospital. So even though the numbers are going up, and you could say it's doubled every 8 days, he's not lying, but the numbers are still quite small. Likewise, patients actually in hospital at the moment, again we see the dark days of April, May, which we don't want to go back to, of course. But if we actually look at it, there's just under 1,000 people in hospital in England with coronavirus at the moment. And if we look at this is patients in mechanically ventilated beds. That's basically intensive care people. What do we see at the moment? Well, again, we see this huge, horrible number back then. But now the latest figures are, is this admitted or people actually in patients in? So this is people in now. This is like the prevalence. So 115. 108 in England there. You get the figures for different parts of the United Kingdom. So I think it's important to keep this in context. So Matt Hancock's right, the trend is dangerous, but we're not in high numbers yet. Thankfully, the death rate in the UK is still remarkably low. Now, the United States is not. We'll come on to that later if we get time. Now, so I think that's just put that in some sort of context, what I think is kind of useful to do. We don't want arrogant complacency. We don't want fear-mongering. We try and get that balance, and it's all got to be based on the evidence. London New Year fireworks cancelled already, of course. In my view, it's just a lot of atmospheric pollution anyway. Some people would disagree with that. Now, this moonshot idea from the government, I mean, the idea of testing everyone, you're going to get lots of false positives. And if you get lots of false positives, because the tests aren't perfect, you get lots of false positives, that means you're going to have 1 million or more people self-isolating every week who don't need to. And if you get 1 million false negatives every week, if you're testing 60 odd million people a week, if you get 1 million false negatives every week, then you've got 1 million people going around thinking they're fine, spreading the virus like bilio, but saying, oh, I tested negative. It's a wonderful idea, but the technology does not exist that is accurate enough. And I like to support the government where I can, because the alternative to government, whether you like the government or not, the alternative to government is anarchy. And I've been in situations where there's anarchy, and I don't like it. It's terrifying. But this idea, someone's actually taking legal action about this at the moment. The idea to spend £100 billion on 10 million tests a day. It involves potentially huge private contracts that have not been tendered. The logistics of this just aren't there. And, value for money rules, this is what the legal challenge is about. I don't know anything about that, but I do know about the risk of the false negatives and the false positives, which, to me, given current technology, means the whole thing is simply impossible. And I really wish the government would drop it. As I said before, if you had Dr. McCoy's tricord and you went zzz, oh, positive, zzz, oh, negative, then that would be fine. But Star Trek technology, unfortunately, does not exist. Now, just a few other examples. Ireland, Republic of Ireland, Dublin, Taoiseach Micheál Martin, the threat is growing. Increasing cases, 104 per 100,000. In Dublin's the highest area. National rate is 53. Cases have increased by a factor of 10 in the last month. You see, it's the direction. It's not so much the numbers at the moment. It's the direction and the potential for exponential growth, an accelerating rate of acceleration, which we know happens. We've seen this back in January, February, March, and we don't want it again. So I can see why they're anxious. Now, the virus in Southern Ireland, Republic of Ireland, community transmission, but then spreading in homes. So, in other words, it's both. New restrictions on gathering, business, travel, what they call a level, they're going from level 2 to a level 3 on their 5-scale restrictions. So again, the direction is not good in the Republic of Ireland. Bit cockeyed today. There we go, that's better. Right, Netherlands. This there's just, as I've just illustrated by that inept click to the wrong screen, there's so many bits and bobs to get right here. I'm not a technical man by any means. Anyway, back to the business in hand, the Netherlands. Regional measures being introduced, cases are increasing, record number of cases for the 4th consecutive day. So likewise, the direction is not great in the Netherlands. France, again, that's a lot of new cases for the day in France, that is a lot. But new infections are down by 8% for last week's on the official statistics. But this is likely to be due to an underestimate due to saturation, testing capacity in regional centres. So actually this is a bad sign, because this shows it's so important not just to look at the figures, but what is behind the figures, what level the figures actually are, and why they are as they are. So that's really a false drop in France. There hasn't really been an 8% reduction in cases, although it looks like it. In fact, it's bad because of this saturation in testing capacity. So France are having problems in testing. The UK were having great problems in testing logistics. Just shows how ludicrous it is to try and do 10 million tests a day with all the false negatives and false positives that would entail. Now, the testing problem will contribute to the spread. So what happens is people think, I might have the disease, can't get a test. Turns out they have, and they go on spreading it. They kind of give themselves the benefit of the doubt. So the testing problem, when symptomatic people can't get tested, that contributes to the disease. And I haven't checked this out yet, but I think the Centers for Disease Control in the United States reversed that previous idea, saying symptomatic people don't necessarily need tested. More on that when I've checked it out. But this idea that symptomatic people need tested and isolated is a fundamental axiom of pandemic control. And in UK and France at the moment, it's not being done for simple logistical reasons. Right, deaths in France, weekly deaths have increased. Last week, the week before. Now, having said that, the death rates are apparently much lower than they were, but they are starting to increase now in Spain and France, as are hospitalisations. So the scale of sick people and deaths doesn't seem to be anything like it was in March, April, but it is increasing, and we've got the whole winter to go. It's this winter that is the key thing. Highest daily toll in the highest past 4 months in France, so highest daily death toll in the past 4 months. So deaths are increasing in France. The last time they're at this level was over 4 months ago. Tighter regulations in these areas: Nice, Marseille, Bordeaux, Paris. Infections now growing faster in the over 75s. Hospital and ICU admissions are rising in France, and of course these two go together. Now, part of the reason, and it is only part of the reason, but part of the reason the death rate's been so thankfully low over the past few months is it was younger people spreading the infection and getting the infection. Now in France, cases are increasing in the older age group, and we know this is going to be associated with an increased mortality, unfortunately. Still going around Europe, Greece again, yesterday, day before, increasing cases. People coming back from holiday seem to be the main people that are spreading it. Masks in all private and public places, excellent, and is mandated. And as far as I know, that is being adhered to. This needs to be the same everywhere in the world, basically. Half the cases are currently in Athens. So new rules: Monday 9 people outdoors, 20 people at funerals, wedding and baptisms are going to be the maximums. So they've gone for 9 as opposed to 6. UK has gone for 6, Greece has gone for 9. Indoor and outdoor concerts have been suspended. People over 68 curtail their movements and avoid public transport. So basically, the Greek government is advising people over 68 to shield, to self-isolate themselves. And it is a legal requirement that employers ensure 40% of their office work is done from home. Now, it's interesting the way that different governments are approaching this in different ways, different rules. And okay, there's differences between countries, but it just shows that this is not so much a science as an art form at the moment. There is science behind it, but if there was the same science, then you would expect the rules to be much more the same in every country. Although having said that, countries are varying, of course. Now, Spain, huge number of increasing cases. Look at that, nearly 15,000 new cases in the day. But of course, testing is much higher than it was back in February, March. More than a third of the new cases are in the Madrid area, which is the current epicentre. Partial lockdown in some districts. 37 of the worst hit areas locking down from Monday, the next Monday, a couple of days' time. Areas where there are more than 1,000 cases per 100,000. That should be 100,000. So basically, if there's more than 1,000 cases per 100,000 of the population, that area gets shut down. That's their criteria. New measures affect 850,000. Zones closed off except for work, educational, legal or medical needs. So people can't travel out of these 37 worst hit zones without good reasons. They've gone for 6, the same as the UK, maximum of 6 people meeting indoors or outdoors. Private or public gatherings will be limited to 6 people and parks will be closed. Don't really get the bit about parks. Parks are outdoors. People can take exercise. As long as people socially distance outdoors in parks, I would have thought it's fairly safe. But that's what the Spanish authorities have said. Maybe they realise that people have not been social distancing in parks and have recognised that as an infection driver in their particular area, therefore have decided to regulate it. But if people are behaving themselves outdoors, the more outdoors activity, the better, I would have thought. Now, going on to the United States. Okay. Yeah. Increasing number of cases. Now, I did check the website just before I came on. Now, news outlets are saying that the 200,000 milestone deaths has been passed, and it is worth just pausing. I mean, 200,000 people, that it's a lot, isn't it? It's a lot of loss. And the death rate in the US is still fairly high. The daily death rate from memory is around about 800-900 a day in the States. It's still quite high. So the news outlets were saying this morning, in fact it was what is now yesterday's news, last evening's news in the UK, but the 200,000 has been reached. I'm sure that's true. This is the official data from the CDC side. It's always a bit behind. Now, there seems to be quite a bit of reflection going on in the United States, which I suppose is good. Where am I? There I am. Right. So the Surgeon General, not picking on the Surgeon General, seems a really good chap. But it is interesting to note that the Surgeon General, Dr. Adams, is by trade an anaesthetist, or in the United States an anaesthesiologist. His expertise is looking after airways and anaesthetising people for surgery and looking after critically ill people in terms of physiological management. That's what anaesthetists do. So that's his area of expertise. He's not a community health. He's not an infectious diseases doctor. So it's always kind of interesting to notice that. Anyway, February the 29th, he said, this is what he said: you may be increasing your chances of getting a disease by wearing that mask. Now, my question here is, given what we knew from previous outbreaks, like SARS, like various influenza outbreaks, like Ebola, so many previous outbreaks, given what they were doing in Taiwan, given what we're doing in China, South Korea, the knowledge that was around about masks already, why didn't these people that are supposed to be the medical experts in the country know this? Now, to be fair, up until I think it was about the 17th of February, 17th of March, I changed my thinking on masks. And to my regret, I was just following the standard opinion rather than going back and looking at the actual empirical evidence. I was following the directors of public health. I was following the chief medical officer. I was following the surgeon general. But actually, if you go back, the data that they should have known about was there. So, it's my fault. But basically, I'm not a community health specialist. I taught nurses for 27 years. I've taken interest in disease all my life, of course, and worked in many different situations. But I'm not a specialist anaesthetist any more than I'm a specialist infection control doctor. But these people should have had advice from the very best, and yet they got it wrong. And they got it wrong. There you go, they got it wrong. So not picking out Dr. Adams, looks like a great chap, but we could have picked on other people, but he was just the one on the news this morning. Dr. This chap, I can't pronounce his name, Dean, Brown University School of Public Health, again from the news outlet this morning. He said 150,000 of deaths. Of the deaths, maybe more could have been prevented. We just didn't take it seriously. We didn't do it right. So as 200,000 deaths is passed today, it is good to think about the reflection on things they got wrong. Why weren't we copying countries like Taiwan that seem to have this all sus from the beginning? There doesn't seem to be that interchange of knowledge. And now 200,000 deaths in the United States. Okay, enough of that. But of course, the other thing is that if this virus had turned out to be 10 times more deadly, I think the same mistakes probably would have been made. We've been fortunate, really, that this virus is not more deadly than it is. It's bad enough, but it could have been so much worse. Now, briefly, Moderna seem to be talking up their vaccine, the Moderna National Institute of Health. They're going to have 20 million vaccine doses pumped out by the end of the year, seeking emergency authorization for high-risk groups if it proves 70% effective. Now, Dr. Redfield was talking about this just the other day, wasn't he? He mentioned that 70% effectiveness figure. So I wonder if they know something we don't. Is this vaccine 70% effective? Now, if it is, that's not 90%, but it's better than 50%. Obviously, a vaccine that's 70% effective will make a significant difference. Then when one comes out that's 80% effective, we can skip on to that one. But it looks like this is coming out first. It's going to be out soon, 20 million doses by the end of the year. And it looks like, we don't know. Until we read the papers, we don't know, but it looks like it's going to be 70% effective, which is acceptable. That will generate herd immunity type features. Now, this vaccine program's had $1 billion already, and as well as that, they've had advanced orders for $1.5 billion already. So the money here is just huge amounts of money. A lot of money being thrown at that. Now, it's a messenger RNA vaccine, which I have not criticised, but said I like the traditional tried and tested vaccine. This will be the first ever messenger RNA vaccine used by humanity. But the big advantage is they can produce huge amounts really quickly. So manufacturing wise, it's good, as they hope to produce 500 million to 1 billion doses of the vaccine by the end of 2021. But if you're a shareholder, your vaccine is 70% effective, and then one comes out that's 90% effective, then your vaccine could become out of date. Things could evolve on the vaccine front, and we could have 500 million to 1 billion doses of a vaccine that's 90% effective. But as I say, we don't know yet. We don't know. That 70% is pure speculation until we read the paper. Now, just a couple of other countries. Burma, Myanmar, increasing cases there, biggest daily rise so far, after weeks without any domestic transmission. So it looked like the pandemic was passing Myanmar by, but now it's not. Most cases seem to be in Yangon, which when I was there was called Rangoon. Low number of deaths. And Iran are saying they're in a third wave. Now, we started off talking about those levels of immunity, so I just want to do a quick bit about that now before we finish. Now, this is very interesting, showing that there might be quite a bit of immunity around already. Now, we've talked about this cross-immunity idea before. We've speculated that the low level of deaths in Africa might be due to cross-immunity. But what do we know from the science? So this is from a publication yesterday. I think it was yesterday. I don't think it was even the day before. I'm pretty sure it was yesterday in the British Medical Journal. Studies have documented SARS coronavirus 2 reactive T cells. So these reactive T cells are there and exist. Now, what these are is we have these white blood cells called lymphocytes, which are the specialist cells for dealing with viral infection. And there's two sorts, there's the big ones and there's the small ones. The big ones are the NK cells, natural killer cells that kill virally infected cells. But the small ones can be divided into B or T lymphocytes, depending on whether they mature in the bone or the thymus gland. And the B cells actually produce the antibodies, as we know, these Y-shaped immunological proteins, which are so essential as part of the immune response part. But the T cells can be helpers, suppressors, or cytotoxic. So the helper cells stimulate the B cells to make the antibodies. The suppressor cells restrict the immune response when it's time to start scaling things down. But the cytotoxic T cells, they will actually kill virally infected cells. So if that's a virally infected cell there, that's the nucleus. These are the viral particles. The T cell will come along, drop chemicals on that cell and kill it. They are cytotoxic T cells. And these play a vital role in immunity. Now, 20 to 50% of people with no known exposure to the virus have these cytotoxic T cells, which will kill a cell which is infected with SARS coronavirus 2. That's quite a profound statement. 20 to 50% of people with no known exposure to the virus yet have a level of immunity. So how novel is this virus? Is an interesting question. The answer is fairly novel, but not entirely novel from this data, because 20 to 50% of people with no known exposure to SARS coronavirus 2 yet have cytotoxic T cells, which are active against cells which are infected with SARS coronavirus 2. And that comes from studies in the United States, Netherlands, Germany, Singapore, UK, Sweden. And the figures vary between 20 and 50. Right, so this immunologist here, at this point there are a number of studies that are seeing this reactivity in different countries, in different labs. So in other words, it's not just one study that's showing that people have cytotoxic T cells which are active against SARS coronavirus 2 COVID-19 inducing virally infected cells. It's different countries have shown that. Different studies, different countries. This does seem to be a genuine phenomena. As a scientist, you know that this is the hallmark of something that has a very strong footing because it's from different studies. It's not from one study. You know, science is all about collaboration of results. One study collaborates, agrees with the results of another study, and that strengthens the initial claim every time it's done. And it's been done many times now. So we can say with a level of certainty that these cytotoxic T cells exist, and apparently they exist in people that have never been exposed to SARS coronavirus 2. Quite profound stuff, really. Common cold viruses, animal coronaviruses. So we know there's 4 circulating common cold viruses, and animals also have coronaviruses. So do dog owners have less severe disease than non-dog owners? It's an obvious question. And if Tim Spector's watching, which I know he's not, put it on the symptom tracker app. It's a really good question. Do pet owners, cats, dogs, animals that can get coronavirus, different coronavirus of course, but it could give some cross-reactivity, does exposure to animals and their potential coronaviruses mean that someone has got a level of community, therefore these a level of immunity, therefore these cytotoxic T cells already exist with some cross-reactivity against SARS coronavirus 2, meaning these people are more likely to get asymptomatic disease, mild disease, and not die. Is that true? Well, we don't know. The study hasn't been done. But it would be a heck of a good one for the COVID symptom tracker app. All Tim has to ask is, have you got a pet? If so, what is it? I don't know. I'm not a vet. Maybe even hamsters carry them. I don't know. Good question, though. Right, so information indicating that there may be levels of immunity already. So New York, London, Stockholm. So what's happened in these areas is that the lifted restrictions, and even although relatively low numbers of people officially had been infected, we looked at that at the start, didn't we? It was those kind of numbers. New York 23, London 18. So even though relatively low numbers have been infected, nowhere near what we'd expect we need for herd immunity, and yet these haven't taken off again. The restrictions have been released and the number of cases have stayed relatively low. Indicating to me that way more people than have thought could have been exposed have not shown up in the antibody studies, either because they didn't seroconvert to make the antibodies or because they tested at the wrong time and the antibodies weren't there anymore. And yet these people could be immune as a result of the presence of the cytotoxic T cells, and to some extent the B cells as well. But probably mostly the cytotoxic T cells that give the immunity. So could be. But as well as that, part of the reason there hasn't been a resurgence of cases is they have the ongoing measures, which of course we need, the masking, the hygiene, all that kind of stuff, the physical distancing, but the memory T cells could be a factor. Now, nearly finished, I know I'm going on a bit today, but Swedish family members, patients with confirmed COVID-19. Now, we have looked at this before, but T cell responses found in those who were seronegative, in other words, did not have antibodies and no symptoms. So about 60% of family members produced antibodies, but 90% had T cell responses. Now, this indicates if family members had a T cell response, then it indicates that they've almost certainly been exposed to the virus, but not developed symptoms. While only 60% developed antibodies, 90% developed a T cell response in the situation where the T cell response was looked for. Very often the T cell response is not looked for because it's a more expensive, more detailed test, whereas the antibody test is pretty straightforward. So 90% had a T cell response. That could indicate we're further through the pandemic than we thought, as illustrated by the lack of resurgence of cases. I mean, I'm not saying they've gone away, but the lack of resurgence of cases in places like New York, Sweden and London. T cells were found in SARS patients in 17 years after infection. Now this is the SARS coronavirus 1, 2003. Patients still have immunity in terms of T cells to SARS coronavirus 1 in 2020, and that is 17 years later. Now, given this data from the SARS coronavirus 1, I see no reason at all why it should not be exactly the same for SARS coronavirus 2. In other words, people could be immune for at least 17 years. And of course, that's when we've tested for. I would expect in a few years' time these people are still immune. Antibodies won't be there, of course, but the T cells will, and the memory B cells will, and that's what confers the immunity. So, T cell response 17 years after SARS coronavirus 1. I expect it to be the same after SARS coronavirus 2, therefore I suspect long-lived immunity. That's why I have stated my position that I believe, I'm open to further evidence, but I believe this pandemic will go away completely because of this level of immunity seen in the SARS coronavirus 1. Now, swine flu H1N1 was another example, 2009 outbreak. Pre-existing reactive T cells had people with these. So we thought that people didn't have immunity to this, but it turns out that because they've had other types of flu, they had a degree of cross-immunity. So they had pre-existing T cell reactivity to the H1N1, and they had milder disease. So this is known from other viral studies as well as coronavirus. This is known from influenza viruses. But the point is we don't know at the moment, so what we require is prospective studies. So what we need to do is we need to look at people who have, we need to test a load of people for these T cells, these anti-coronavirus cytotoxic T cells. We need to test them, find out who they are, and then see if they go on to get the infection. And if they do go on to get the infection, do they get a severe infection, or as we would expect, do they get a much milder infection? But to my knowledge, no such study is being done. Now, the ideal place to do this study would be in the placebo group of the vaccine studies, but it's not being done, unfortunately. So mapping pre-existing reactivity to clinical outcomes needs to be done. That's got to be prospective, but it's not being done. It's not being done in the placebo arm of the vaccine studies, which is a pity because that data is being collected anyway. So even although this is immunologically the most important, in my view, the most important piece of immunological information we need, no one is studying it. And that is surprising. All the immunologists in the world realise the importance of antibodies and the importance of the T cells. Having realised the importance of the T cells, they have decided to go to the pub for a drink or have a cup of tea. No one seems to be studying this. So we need a study that's looking at the prevalence of the cytotoxic T cells and looking forward to see if they get infected, just the same as we're doing with the vaccine. And we've got all these tens of thousands of people in this placebo arm of the vaccine where this could be being done, but it's not. So it just seems such a wasted opportunity. Thank you for watching this video. As always, a bit of a long one, so if you stayed to the end, a special thank you for that.